Hello, everyone, and welcome to our live session today. Before we begin, I will be going over a quick starter presentation to welcome you all and introduce you to our program and various opportunities if you have, of course, not attended one of our shadowing sessions previously. I do want to highlight that Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic status, abilities, or location. My name is Jesus. I am the Chief of Program Planning here at PHS, and I want to thank you all for attending today. Now, let's get started. Just a little PSA, we do have closed captioning for all of the sessions to accommodate all students. This setting is available on the bottom of your Zoom screen, and if you need any assistance enabling the transcript, please direct message one of our team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations for how we can improve, you can email us at info@prehealthshadowing.com. So since this is an international program, we want to know, where are you guys Zooming from today? You can drop it in the chat, just so we have a better idea. I myself am calling from the wonderful island of Puerto Rico in the Caribbean. Okay, thank you so much. I see there's a lot of people, okay, from all over. Thank you so much, you guys. If you want to stay in the loop, you can follow us on social media. We are active on both Instagram and TikTok, or you can also sign up for our email list on our website to never miss a session. We do have some wonderful opportunities for you as benefits of being part of PHS. So if you are looking to get research experience, but you dropped the ball on applications this year and did not get any because of COVID, I am excited to announce that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research on a plethora of topics, fields, and locations. This program is 100% remote, which means you have the power to connect with anyone. This is an 8-week program that will begin on June 21st. And for more information, you can fill out the interest form sent in the chat below, and we will get back to you as soon as possible with any additional details. We have also partnered up with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources, such as study guides to help you prepare for your standardized tests, like the MCAT, the NCLEX, or the PCAT. If you fill out our short survey in the chat, we will definitely get you signed up for these deals for free as well. We would also like to draw your attention to another amazing program, that being Neolith. Neolith is an online mental health platform for students. For pre-health professionals especially, we know that isn't easy, so that is why we partner up with Neolith to spread the word and offer free access to their services if you use the link in the chat or enter the code PREHEALTH when signing up. Additionally, we are really excited to announce that we have partnered up with Krispy Kreme for you to purchase one delicious dozen donuts to enjoy with your loved ones. With a donation of $10, you'll be able to receive your treat while also helping us here at PHS. More information and instructions can be found by clicking the link that was also sent in the chat. We also just got our PHS and this is another way to represent as our mission. Mask for Masks is another need the COVID pandemic. Community healthcare workers without their proper support struggling sorry, you guys. There appears to have been a problem. I'm really sorry. Okay, but we are back.
I can go ahead and take care of the
mask
presentation. Okay, so I'll just go ahead and share my screen. Let's see where we were. So I believe he was at the donuts. This is our PHS merch. If you go to the link in the chat, you can get our PHS merch and it'll help us raise some funds to get our research program going and all of the exciting things we have to offer at PHS. So next we have a wonderful partnership with a women-led nonprofit called Mask for Mask. They actually donate 4 masks for every 4 masks sold. And these masks that they donate actually go to the homeless community and healthcare workers without proper PPE and just people in need during the pandemic. So it's a really good opportunity to get amazing masks and also be able to donate it to people in need. PHS also gets 10% of the proceeds. And a good thing is that you also get 15% off of your first order with our code that you can see on the screen. So it's a great opportunity. So if you need some new masks during the summer, you can definitely go to their website and buy some masks. If you're interested in being more involved at PHS, you can become an asynchronous volunteer or a team member. Being a team member means you're more involved, you're able to lead groups of volunteers, you're able to collaborate with other team members, and you basically start on new initiatives and projects on your own. One example is one of our team members is the chief of podcasts, and so he has a group of team members that help him do that. So it's really fun and you can get to lead huge projects. Another opportunity we have, if you aren't able to have a lot of time on your hands and your schedule is really busy, is volunteering asynchronously, which you can do with the first link there. And what you do is you can do it on your own time at 3 a.m. It's like professional outreach and little tasks that you can do and get your volunteer hours for. So if you are a high school student, we have a program here at PHS called HTP, which means High School Training for PHS. And it's essentially an introductory organization to help high school students learn about pre-health and the healthcare field and what it is like to even be in the undergraduate years, getting your master's degree, getting your graduate degree, or your doctorate degree for health, and how health works and how medicine works, and just introducing them to the system essentially. So this is really important for students who don't have any idea what they're doing and are interested in a lot of things. So if you'd like to be involved with that, you can fill out the application for the high school training program in the link in the chat. So if you're looking to get published, you are able to write articles, reflections on our live sessions, reviews, and success stories, and you can submit your writing at www.prehealthshadowing.com/blog submissions. I'm actually the editor-in-chief, so I'll be looking through your submissions and getting them published and promoted. So if you happen to write anything related to health, medicine, sociology, or even student life, you can definitely submit it and we'll get it checked out for you and you can become published on our website. Another thing that we have is our diversity initiative. So if you have any nominations, any professors or professionals that you know who are able to collaborate and communicate on issues such as racial disparities, LGBTQ+ health, sexism in education, and a lot of issues with diversity in the healthcare field. If you have any professionals or people that you know could contribute to that, you can definitely nominate them using the link in the chat. We have our diversity panels where we talk about the key issues in health and just learn more about how to become a better healthcare professional. And we also humbly ask that if you are able to, and if you know other people who can, that you please consider donating via our Venmo and PayPal to Pre-Health Shadowing, because it does take a lot to keep our program up and running with our Zoom and our website and all of the programs we're running. So if you do have the time and finances, please consider donating to us. Otherwise, we ask everyone to share the knowledge about pre-health shadowing. So everyone gets a chance at shadowing opportunities at a time where we keep getting rejected from offices and clinics because of the pandemic. And during this session, I'd like to remind everyone that you are able to type any questions you have for the speaker in the chat. Our co-host will take the questions at the end of her presentation and ask them to the speaker. You can also, if you'd like to ask the questions directly to the speaker by unmuting yourself, you can do this by raising your hand. I'll call on you and you can unmute and raise your questions directly and have a discussion with the speaker at the end of her presentation. And I just like to remind everyone once again to take good notes. If you've been here before, you know that we have our post-shadowing assessments, our multiple choice post-shadowing assessments that are based on the live session. And when you take this, you get your digital certificate. And I'll talk about how you can actually do this if you're new here at the end of the presentation. But this is how you should take good notes, just to know and refresh your memory when you're taking your assessment. And last but not least, I'd like to remind everyone to keep your cameras on if you are able to and if your circumstances allow you to. We really like to see everyone's faces because we feel a little closer at a time where we have to socially distance and have our masks on. So if you're able to, please consider having your cameras on. Last but not least, I also ask everyone to keep yourself muted unless you're asked to, just so we don't disturb the presentation and we have our attention to our live session and our wonderful speaker. And that's all. I hope you guys have a great live session. Thank you for being here. Dr. German, you can go ahead and start sharing as soon as you're ready.
There we go. All right, can everybody see that okay?
Yes, we can, thank you.
So my name is Rita German. I'm a transplant hepatologist. We'll get into what that means, but I just first wanted to say thank you so much for having me here. I'm really excited to chat with you all and to tell you a little bit about myself and about how I got to where I am today and kind of my career path, and hopefully give you a little bit of insight into how I got here and answer some questions. Hopefully this will be a fun session. Right. So I have no financial disclosures. And so we'll talk a little bit about me and how I got to my career path. What is gastroenterology and transplant hepatology? I know that there was, I think there was a session in May maybe for a gastroenterologist. So we'll talk a little bit about that, maybe review that, and then talk a little bit more about what transplant hepatology is. We'll get into how I chose this field, talk through some cases, and have our Q&A. So first, we just have a few poll questions. So the first one is, where are you in your education? This will help me understand a little bit about who the audience is and who we're chatting with. So high school student, undergrad, graduate, out of school, or other. Are we going to do all the polling questions? I wasn't sure if we're doing all together or one at a time.
Yeah, so we have all of our polling questions at once. And we have our first question, where are you in your education? And then, where are you location-wise? And our last question is, what school are you thinking of applying to? So I'll give everyone about 40 more seconds to get everything in.
So the majority looks like they're undergrad students. We've got some high school students, graduate, some out of school, and kind of split in the US and then a good amount outside the US. And a lot of people thinking of applying to medical school, PA school, pharmacy school, and other. Awesome. Okay. Very cool. Let me do this. Okay. So I'll just talk a little bit about myself here. So I'm from Chicago and I wasn't born in Chicago, but I've been there since I was about 6, and thought that I would be in Chicago my whole life because my whole family's there. And as you saw from my first slide, I'm actually now in Madison, Wisconsin. So things change, sometimes in a great way that is unexpected. But so I definitely didn't think that I was going to be in Madison, Wisconsin. I thought I'd be in Chicago forever. But then life just takes you other places and takes you kind of on a journey. So first I went to undergrad at Northwestern in Evanston, Illinois. I double majored in biology and psychology, which I really enjoyed. I mean, undergrad is hard. Yeah, as you all know, there's a lot of classes. You take organic chemistry. So I did the pre-med course, but I wasn't positive that I actually wanted to do medical school. I kind of, my whole undergrad, I was like, yeah, I think I'm going to apply to med school. I think so. But I wasn't 100% in it. So I wasn't sure. I kind of was exploring other options. So that's why I was double majoring in biology, psychology. I was exploring other classes. But I kept thinking, yeah, I think I'm going to do pre-med. I think I'm going to apply to med school. So I'm still going to take all the courses. So I still took all the required courses, thinking that I probably would end up going to medical school. But I did other stuff outside of just schoolwork. So it's good to get involved in other things. I was active in Greek life. I was actually competed in ballroom and Latin dancing and did a lot of dance competitions and participated in this ballroom group there. So, and I spent a lot of time doing that as much as I could outside of studying, obviously. I also tutored high school math and science, try to get involved in a lot of other activities, different clubs and things like that. So obviously you're going to work hard and you're going to get all the classes done, but then you just want to enjoy your time too, because you never really get another chance to be an undergrad. And it's a great time in your life and a time to learn a lot, but also time to figure out what you want to do and figure out what your hobbies are and build friendships and relationships. And a lot of the connections you make in undergrad will, help you in your future career as well, because a lot of people that I met in undergrad are also ended up also becoming physicians or going down other paths, and you still connect and make connections that way. So I really loved my undergrad experience. So as I mentioned, I wasn't positive I wanted to do medical school right away. I did do all the pre-med courses. I took the MCAT. I didn't do great on the MCAT. I think I wasn't fully into it. I took the Kaplan course, and sometimes you're just not a great test taker. And so I didn't do great on my MCAT, but I was like, well, if I'm going to do medical school, then I need to get more life experience. I need to get more volunteering experience, more research experience. So I ended up taking a gap year, and I'll talk a little bit more about what I did in that gap year in just a little bit here. So then I took a year off, and then I went to medical school after that. So I obviously decided to do medicine after all. So I went to UIC in Chicago. UIC is actually an interesting med school because it actually has 4 locations. So one's in Chicago, one's in Peoria, Champaign, and Rockford. So I was at the Chicago campus where you stay the whole 4 years. And med school's hard. It's really hard. It's the first 2 years, things are changing in the medical school curriculum, but the first 2 years while I was doing medical school was basically book stuff. So you just had classes, you read your books, you took tests, did all the coursework. And then 3rd and 4th year were really when you did more of the hands-on experiencing, shadowing in the hospital, seeing patients, et cetera. Where I am right now at University of Wisconsin, the coursework is kind of condensed into the first year and a half so that they actually have more time. Students have more time in the hospital, more time seeing patients, more time trying to figure out kind of what path they're going to go on after medical school, which is really nice. So med school's hard, but I did enjoy it. So the first 2 years were tough. One of the things that I didn't do in undergrad was, a lot of the people I realized in med school had taken anatomy or had taken some of the other courses that you end up taking in medical school. And so I felt a little bit behind, I would say, in the beginning, especially with anatomy, because anatomy is a really tough class and you learn a lot very, very quickly. But I caught up and it ended up being, my favorite class actually. And so you don't have to take the pre-med course. I mean, you obviously have to take pre-med courses in undergrad, but you don't have to take all the classes that you're going to retake in medical school, but it wouldn't be a bad idea. I would say I probably should have taken maybe an anatomy course in undergrad, thinking about it now. And that might have helped me at least not feel so kind of panicked when I started learning anatomy and trying to understand all the terms and all that. So, but otherwise it was really enjoyable. You learn a lot. I tried to do a little bit of global health work. I traveled to Spain for a month between M1 and M2 year to work in a hospital in Spain through this organization called IFMSA, which is the International Federation of Medical Student Association. I was active in the American Medical Student Association. I was active in the American Medical Association. AMSA is a great organization that I got involved in medical school. I was, chair of different committees. There was a global health committee. There was a health equity committee. So it's a lot of, you do have time to get involved in these other activities during medical school. I tried to build kind of relationships. I was a mentor during my second year to mentor first year med students to kind of help them along the process. And then same thing, I had a mentor that was a recent graduate who was a resident, who was my mentor and would tell me things about kind of things to expect. And then again, still, I tried to find time for myself with the things that I enjoyed, because med school is really hard. And again, I joined a salsa dance company, and dancing has been, part of my life, my whole life, and I didn't want to give that up. And so I wanted to make sure I was doing something for myself and for my sanity. And I also developed a really good group of friends where we kind of studied all together, and it was my core pod of study groups. So just having people you can rely on too, because again, I mentioned it, I mean, it's tough to get through medical school. And so it's good if you have kind of your support system helping you along. So then after med school, I did residency at University of Chicago. I told you, I thought I'd be in Chicago my whole life. So I just made the rounds of all the universities. So I went to med school, residency at University of Chicago. I did internal medicine residency there. Absolutely loved it. It's a great program, met a lot of amazing people. And then so I also got married at the end of medical school right before residency. And my husband and I were like, well, if we're going to move, we'll move for fellowship and then come right back to Chicago, because probably after that, we're never going to move. We're just going to stay in Chicago. So I applied for fellowships outside of Chicago thinking, we'll go there for a few years, we'll come back. And so I applied and I matched at a fellowship at University of Wisconsin, which is where I am now. And so I did fellowship there. I did my GI and hepatology training there. And then I stayed on for an extra year for transplant hepatology. And I'll talk about that timeline a little bit more. And then I, initially said I fully expected to come back to Chicago after finishing fellowship, but we actually fell in love with Madison, and we fell in love with, I absolutely loved my program. I loved the people that I was working with. And so I took a full-time job here. So I've been in my full-time job now for about a year and a half, almost 2 years. Since finishing fellowship, and I've really loved it and enjoyed it, and we're still close to Chicago. And so, we're making it work. And I also had 2 kids during fellowship, so it is possible to have kids during this training too. And so we're really enjoying our time here. And yeah, I feel like I may never leave Madison now. So I'm a changed woman. So how did I become this transplant hepatologist? So I kind of mentioned the timeline already, but as far as how long this actually takes. So undergrad, 4 years. I said I kind of did that interim gap year. Medical school is typically 4 years, but there are people that do an extra year for an MPH. Sometimes people do 3 extra years, 2 to 3 extra years for a PhD program. Then internal medicine residencies, 3 years. Some people end up taking a chief residency program, chief residency year, which is another 1 year. And then GI hepatology fellowship is 3 years. And then the transplant hepatology fellowship is 1 year. So quick math, it is 11 years of training. It's a long way to go. And people are like, well, you could have been a surgeon by that point. And I was like, well, I didn't want to be a surgeon. So this is what I wanted to do. But the nice thing is that, after medical school, once you get into residency, you kind of feel like you have a job. I mean, it's not like you're still in training and you're still doing stuff, but you do feel like you're in the workforce, you're getting paid, you have a job. Your time is not always your own because you're obviously on a, specified schedule. So you don't have too much flexibility as far as time. The further you get along, fellowship is a little bit more flexible. And so it's a long road, but it's not you're doing stuff along the way and you're enjoying life and having a good time. So I really enjoyed my training. I was like, I'm not in a rush to be done. This is great. I love learning. I'll keep doing this. And, I had joked with my husband that I was going to do an MPH after fellowship, and he thought I was crazy, but I still might, there's never a bad time to do it. So this is kind of my road, how I got here. The one thing I'll say is that there is a combined fellowship that you can do transplant hepatology and GI fellowship in 3 years. So you do all of your GI training in the first 2 years, and then the last year is left for the transplant hepatology portion of it. And they've kind of created that because, as I mentioned, this is a long road. So there's this kind of accelerated fellowship that you can do that combines it into 3 years so that you don't have to do another extra year of training. For me, I chose not to do the accelerated 3 years just because, number one, I wanted more research time because it kind of condenses and cuts into your research time. I had kids during that time, so I kind of needed some time off anyway. And again, I wasn't really in a rush to finish, and I was enjoying my time. I wanted to be a really good endoscopist, which is the time you get during the GI fellowship. And I wanted to be a good transplant hepatologist. So there is that option, but I chose not to do it. And a lot of people can choose one way or another depending on their, life circumstances. So what did I do during the gap year? So I mentioned, I was never quite sure if I wanted to do med school during undergrad. I kept saying I'm pre-med, but I really didn't get enough experience during undergrad to make me a competitive applicant for med school. And then I didn't do fantastically on my MCAT that I thought that would get me through. So during the gap year, I ended up doing a few different things. I was a research technician at UIC. I did clinical research in the Department of Anesthesia at a local hospital in Evanston. I was a research technician at Argonne National Labs. And so I did a little bit of basic science research. I did some clinical science research. I did a Costa Rica trip through a medical volunteer trip through FMRIC. It's the Foundation of the International Medical Relief of Children. Phenomenal program. I absolutely loved this trip. It was only about 10 days, but we got to volunteer in a children's clinic, and it was just incredible. And it's a great program to get involved if you want to do some global health and go on different volunteer trips. They have a lot of different locations that they do this in. And then the research parts of it. So a lot of these, the way I got these jobs is really through some personal connections. My parents had a friend who worked at the hospital, and they asked to see if there was somebody that needed to have someone help with research. And that's how I got my, clinical research job at, in the Department of Anesthesia. So you kind of use all the resources you have for you. So use the people, that you're meeting through these sessions. If there's something that's interesting to you, reach out to those people and email them, and, you never know where it's going to get you. So a lot of times the things that we get to pursue and get to experience is really through connections that we build. So it's good to start building them early on. It's good to start, even in undergrad, start working in research. In undergrad, I did work in a research lab as well that I really enjoyed doing. And that's why I kind of thought, well, maybe I'm going to do research instead of medical school. But so it's really good to just kind of get involved early and just test the water, see what you like and what you don't like, and do some basic science research, do some clinical research, get involved in a lot of different things. And it doesn't have to be exactly related to what you want to do in the future. It could just be something different, just anything that you enjoy and like to do, and that'll get you some experience. So I really enjoyed kind of all the different things that I was doing at this time. And then after the gap year, I went to med school, and I felt like I had a lot more experience under my belt, talking to patients, working with patients, working in the basic science lab. So it was a really great year that I was really happy I ended up taking off. And so kind of I mentioned, so extracurriculars, make sure you're getting involved, make sure you're volunteering. It's obviously super hard right now for everyone, and it's really unfortunate that COVID has made it so difficult for everyone and pre-health students to do this. So that's why this group is so incredible that they're even giving you volunteer opportunities. So take advantage of all of those opportunities. It's really incredible, and really adds to, you know, your resume, and adds to your when you're applying to school, whether it's medical school or PA school or whatever it is, it may be that it gives you a you know, a leg up that you can say, well, I've already done this and this and this, and that definitely matters. And you can get involved in public health activism, in research, but also take time to do something for yourself. You know, I really advocate for that. You know, you need to keep your own mental health very stable, and make sure you have people around you that are supportive of you and supportive of what you're trying to accomplish here. And also know that, you know, it's okay to change your mind. It's okay to take some time off and figure out exactly what you want to do. Because in the end, hopefully that'll help you really get to exactly where you want to go. And so just like the year off, you know, initially I was like, well, am I doing the right thing? Is this a bad idea? But in the end, you know, it was a great idea for me. It worked well for me, that I was kind of recharged and ready to go, and said, yes, this is definitely, now I understand, this is what I want to do. And I can't imagine doing anything else now. Okay, so what does a gastroenterologist do? So we'll cover the GI portion first, and then we'll get into the transplant hepatology portion. So as a clinician, you treat diseases involving the GI tract. Essentially, the way we say it is like you're treating basically anything from the mouth to the anus and in between. So esophagus, stomach, small intestine, colon, rectum, and then there's a bunch of other organs thrown in there. So there's the gallbladder, there's the bile ducts, the liver, the pancreas. So a GI doctor, you know, I'm a transplant hepatologist, so I did an additional training to specifically care for patients with liver transplants as well. But a GI physician, depending on where you're training and depending on where you're training, depending on where you're going to work outside after you complete fellowship, you're going to take care of liver patients as well. So you learn about the pancreas, you learn about the liver, all of that. There's a lot of different types of disorders that a GI doctor treats. That's one of the things I really love about GI, is that there's a lot of variety in the things that you treat and the things that you see, and the acuity of things. So you see gastrointestinal bleeds. So people with peptic ulcer disease, so ulcers in their stomach or in their small intestine that are oozing blood or bleeding excessively and profusely, and you have to do a procedure quickly and stop the bleeding. So those are definitely one of the main aspects of our job. We treat patients with inflammatory bowel disease, so ulcerative colitis and Crohn's disease. People with irritable bowel disease, that should say irritable bowel syndrome, IBS, sorry about that. Celiac disease, so patients with gluten sensitivity and intolerance. GERD, so gastroesophageal reflux, things like pancreatitis, things like hepatitis, fatty liver disease, cirrhosis. So all of that is something that a general GI physician will do and will see in their practice, and a lot of other things as well. This is just kind of a brief list. And then, of course, we also do colonoscopy and endoscopy. And those procedures could be either for just screening purposes, so like a screening colonoscopy. Recently, the USPSTF and actually the GI societies as well have lowered the screening age, starting at 45 instead of 50, where it was. And the point of colonoscopy is to remove polyps. And polyps are typically precancerous lesions. So it's basically a spot in the colon that, if you leave it there, eventually over time, it can turn into cancer. So we do colonoscopy to remove those polyps, get rid of them, so they don't have the potential to turn into a cancer. We treat GI bleeds, as I mentioned, so ulcers, other things that can bleed, lots of other disorders. We do foreign body removal, which essentially means, if somebody swallows something or put something up the other end, we go in and take it out. Then we also do placement of PEG tubes, so percutaneous endoscopy gastrostomy tube. So it's a feeding tube. So we do a lot of those. Actually, I did a lot of those in fellowship. And it's for patients who either have, an older patient, let's say, that has esophageal cancer and can't swallow. And so they need to get some sort of nutrition. And so we place a PEG tube in them to allow them to eat, or somebody that has a stroke and they have lost their ability to swallow. So then that's another reason why we put a PEG tube in. And then there's other procedures called ERCP and EUS. So ERCP is endoscopic retrograde cholangiopancreaticogram, and an EUSN is an endoscopic ultrasound. And those two procedures are typically performed by what's called an advanced endoscopist. So after GI, you can actually do another fellowship called advanced endoscopy to learn how to do these other types of procedures. We actually do them during fellowship as well, but you don't get as many as you would during an advanced endoscopy fellowship. And these procedures, so an ERCP is meant to go, you use a slightly different scope that you do for endoscopy, and you go through the mouth, into the esophagus, into the small intestine, and then you actually thread a little wire into the bile ducts. And this way you can actually remove stones that are stuck in the bile ducts. You can put a little stent in the bile ducts if there's a cancer there that you need to treat. So it's a really cool procedure that is, it has a lot of uses for it. And an EUSN is an endoscopic ultrasound, which basically means an ultrasound, but that's done internally. So if you basically use an ultrasound, you put it down someone's esophagus into the stomach, and then through the stomach, you can use an ultrasound to look at the pancreas. And that's a way we diagnose things like pancreatic cancer, look for spots in the pancreas. And you can actually do other procedures through it. So it's really, really cool, actually, technology. Excuse me. So this is just a picture of a colonoscope. So this is an endoscope actually, but a colonoscope looks similar to this, just a little bit bigger and a little longer. And essentially you insert it through the anus, and then you go all the way through the whole colon, all the way to the cecum, which is the end of the colon. This is the appendix right here. And so you make it all the way to the end of the colon, and on your way out, you start taking off any polyps you might see. We send the polyps off to our pathologist. They tell us what type of polyps they are. There are some benign polyps, meaning some polyps that have no ability to turn into a cancer, and others that can turn into a cancer, and those are the ones that we want to remove. So this is kind of what it looks like. We're standing behind the patient, we're inserting the colonoscope, and then we've got a camera here, or a video feed that we're looking at to see the inside of the colon. So it's really pretty neat, and you can go on YouTube and kind of YouTube some videos of a colonoscopy. You know, people are like, well, that seems really gross. I'm like, well, it's actually not, because first of all, the colon is cleaned out, right? When we're doing this, the patients have already drank the prep, so they've all the gucky stuff is gone. And so when we go in, it's actually pretty clean, and it's a little bit like playing a video game, I would say. So you're kind of going around the curves and then trying to cut off these polyps and lassoing it. So you have to be pretty, get pretty good at doing these. And during our fellowship, we end up doing probably over 1,000 colonoscopies and endoscopies. And really, you need that many to get really good, really good at this. And this is what it looks like to do an EGD or an endoscopy. Again, it's where you insert the endoscope through the mouth, into the esophagus, into the stomach. And we look at the first part of the small intestine, and that's about as far as we can go with this particular scope. We do have other scopes that can actually go way further into the small intestine. No, we cannot meet in the middle. If we do a colonoscopy and an endoscopy, there's a lot of small intestine in between. Patients ask us that all the time, mostly joking, hopefully. But we do have other endoscopes that can actually snake their way all the way through the small intestine and can go pretty far. So that's another type of scope. So some pretty cool procedures that we get to do. And I really enjoy kind of the variety and doing all sorts of things. So this is a little bit of a busy slide, but these are all the things you can do after GI fellowship. So so after GI fellowship, sorry, this is just GI fellowship, you can do an advanced GI fellowship, which is all of the ones back here. You can just go into private practice. You can go into academic medicine after that. So there's a lot of things you can do after GI, depending on what it is that's interesting to you and what you would like to do. So let's say you finish GI fellowship and you want to go into private practice. So you can join a practice anywhere you want. You find a practice, you join that practice, and then you're doing a lot of procedures. You're seeing a lot of patients. Usually they're affiliated with a different hospital. So you're doing a week or two on inpatient service in the hospital and seeing patients in the hospital and doing acute procedures that way. You can go into academic medicine. So that's what I do. So that means being in a big hospital system, seeing patients in and out of the hospital in different settings. So I actually work at UW Hospital. My hospital is also affiliated with a Veterans Association hospital, a VA hospital. So I actually split my time between the main UW hospital and the VA. And so I get to kind of see a lot of different patients, do a lot of different things, be in a lot of different settings. And so it's it's really nice. As far as advanced GI fellowship, so I mentioned obviously Transplant Hepatology Fellowship. That's what we'll talk about in a little bit. You can actually do now an IBD subfellowship. So sometimes people take the last 6 months of their GI fellowship to study inflammatory bowel disease and to do a lot of clinic and get more expertise into IBD. And then you can do this advanced endoscopy fellowship, which is that ERCP and EUS. That's where you learn to do a lot of that. And this is what it looks like to do an ERCP. So this is the scope coming down, and then you thread a little wire up into the bile ducts. You can also thread a wire into the pancreatic duct. And so it's a way that you can visualize the inside of those bile ducts and the pancreas duct. And then there's a lot of actually other advanced GI fellowships that are coming out. There's a nutrition fellowship. There's a bariatric surgery fellowship, the endoscopic surgery. So we can do a lot of endoscopic bariatric surgeries now where instead of doing an open surgery or an invasive surgery laparoscopically, you can actually do it internally, which is really, really interesting. And then the Transplant Hepatology Fellowship, which is what I did, is to specifically learn to take care of patients before and after a liver transplant. So I don't actually do the physical surgery, that's a transplant surgeon, but I do the medicine side of things. So I take care of patients before and after their transplants on the medical side. And then I also see all other liver diseases and do endoscopy and colonoscopy. So after you do GI hepatology fellowship, let's say if you go into private practice, you'll end up seeing a lot of hepatology patients. You'll end up seeing lots of patients and taking care of patients with liver disease. And then let's say they need a liver transplant, then you would send them to a transplant hepatologist over, usually it's at an academic center. So smaller centers don't have the capacity to perform transplants. So that's why I end up staying at UW as well, because if I went to a private practice, then I wouldn't actually be able to use the transplant hepatology part of my training. There are some programs that are kind of building on that now where they kind of have a dedicated person that really sees most of the liver patients. But again, if that patient needs a liver transplant, then you send them over to another hospital that has a transplant center. All right, so what do I do? Or what does a transplant hepatologist do? So again, we take care of patients with any type of liver disease. So that could be hepatitis, so viral hepatitis like hepatitis A, B, or C. Patients can have hepatitis from medication-induced liver injury or something like autoimmune hepatitis where their own body is attacking their liver. Fatty liver disease is something that we see very, very frequently. This happens in patients who have obesity, diabetes, high blood pressure, high cholesterol, something called metabolic syndrome. And fatty liver disease is very, very common. So in the US, 1 in 4 people, not even patients, 1 in 4 people in the US has fatty liver disease. So it's becoming very, very prevalent, and it's because of the rising rates of obesity. And so we see a lot of these patients. We also see a lot of patients with alcohol-associated liver disease. That's actually a little bit more of my specialty as well. I'm actually, we're starting a clinic to treat patients with alcohol-associated liver disease and treat their alcohol use disorder in combination with a addiction medicine specialist so that they're getting their care fully all together. And it's really, really exciting. The pandemic has kind of exacerbated a lot of patients' alcohol use disorder. And so we're seeing a lot of really, really sick patients coming in more and more. I mean, we were seeing it before, but it's been rising, and actually rising in younger people. So that's a little bit scary too. I also take care of patients with genetic causes of liver disease. So there's something called Wilson disease, which is a copper overload syndrome. There's something called hemochromatosis, which is an iron overload syndrome. And then obviously we take care of patients with cirrhosis, and cirrhosis can develop from any of the things that we've talked about. So any of those etiologies can cause your liver to become cirrhotic. And then cirrhosis is a condition that we take care of. And then again, I take care of patients before and after they receive a liver transplant. So I basically have to evaluate patients to determine whether or not they're candidates for a liver transplant. So that's a really hard part of my job. And sometimes a part that I really don't like, because we don't have enough livers to give a liver transplant to every single patient. And so it's a matter of responsibility to the patients and responsibility to the donor families and to the donors of who will get that organ. And so there's a lot of really sick patients waiting for liver transplants that may not receive them, or a lot of people that are evaluated for a liver transplant that maybe don't qualify for a liver transplant. So it's a tough part of our job to tell people that they may, it's a great part of my job to tell people that they are transplant candidates, but it's a really tough part of my job to tell people that they are not transplant candidates. We won't go into the complexities of that, but there's a lot there. Until we get ways of having an artificial liver transplant, it's always going to be this kind of conundrum. And then, of course, I work with transplant surgeons to decide on type of liver transplants needed. Sometimes patients need deceased donor liver transplant. Sometimes they get a living donor transplant. We'll talk a little bit more about that. And then I've managed their immunosuppression medications and complications after transplant. So patients get put on a lot of immunosuppression. So we suppress their immune system so their body doesn't reject the liver. Now, the liver is actually a pretty cool organ because it already sees all the toxins in our body, because it metabolizes a lot of the medications we take. It clears out the toxins in our body. So it can handle actually a little bit of having someone else's organ in the body, but not to the extent that they don't need immunosuppression. So most people do need medication to suppress their immune system, to not let the body reject the organ. And so we manage all of that. We manage the complications after transplant that may arise. So it's a pretty cool part of my job, and I do a lot of different things. And that's one of the main reasons why I love this field. So let's go through a case. So we've got a 45-year-old female presents to the emergency room with dizziness, fatigue, 2 days of black stools. When we see black stools, that means that there's usually, this is called melena, and melena means that there's usually blood in the stool. It turns black if it's traveling through the body. It becomes oxidized, and that oxidation process makes it turn black. So when someone has black stools, that makes us think, oh my gosh, they're having a GI bleed. They're bleeding somewhere in their GI tract, usually from up high, usually from their stomach or their small intestine, because by the time they travel through the small intestine, that's when it turns black. She's been taking ibuprofen around the clock. Ibuprofen is a known cause of ulcers in the stomach and small intestine for the past 2 weeks after hurting her ankle running. She's got no other medical issues. So she comes into the emergency room, you check her blood pressure. It's 90/60. That may be normal for her, but that's actually maybe a little bit on the lower end. Her heart rate is elevated, 110. A normal heart rate, is between 60, 70. And her respiratory rate is 18. That's about normal, maybe a little bit higher. It's 2 a.m. and the emergency room calls the GI fellow on call. And so you have to come to the hospital with your attending to perform the EGD, the endoscopy. So you come in and you do the endoscopy and you see this. So this is an ulcer, and you see this line. Well, that's actually squirting blood. So that's a straight line of squirting blood. So that's a little bit of a terrifying sight at 2 a.m. when you go in, but that's what you're trained for, and that's what your job is, and you know how to fix it, and that's really exciting. This is actually a real picture that one of my colleagues took maybe a week ago and sent it to us. And so then you fix it. And that's what's really cool about GI is actually you can fix something right away. So these are clips. These are tiny. They look big on this picture, but they're actually like teeny tiny clips. And you literally clip the vessel shut. And so he put 2 little clips on it, and it stops the bleed. And sometimes we inject epinephrine into it as well to help it stop bleeding. So there's different ways we can treat this. We can burn the vessel. We can clipping it. We can spray it with something called hemospray. So there's a lot of options of how we can fix this bleed. And now you've saved a life, and it's pretty satisfying. So it's pretty amazing the things that we can do endoscopically. So now you got another case. You have a 45-year-old male who's got cirrhosis, which is scarring of the liver, which is something that I treat, and it's related to alcohol use. He comes to the emergency room with vomiting blood and black stools again. So this time he's vomiting blood and having black stools. So, something's bleeding internally. And this has been going on for 12 hours. His heart rate's pretty low, 85/50. This would be blood pressure. His heart rate is 112, so it's elevated. And his hemoglobin is 7, so his blood counts are 7. That's pretty low. For a 45-year-old man, it should be between 13 to 15. So you're like, okay, he's definitely bleeding. It's 1 in the morning, and the emergency room calls the GI fellow. Again, you come to the hospital with your attending, you perform the EGD, and this is what a normal esophagus should look like, but this is what you see, this one. So these are called esophageal varices. So in cirrhosis, what happens is when you have scarring of the liver, all the blood that's supposed to flow from your gut, from your stomach, from your small intestine, from your colon, all of that blood that's supposed to go through the liver back to your heart can't get through because there's so much scar tissue in the liver. There's just no path for it. So it has to find other venues. It has to find other ways to get back to the heart. And so what happens is it builds up these big blood vessels in the esophagus called esophageal varices. And varices can happen actually in a few different places. You can actually get varices around the belly button. You can see it on people. You can get varices in the rectum. You can see that during a colonoscopy. And you can get them in the stomach as well. So you can get esophageal or gastric varices. And these happen in patients with cirrhosis very frequently. And a lot of times what can happen is they can bleed. And this can be life-threatening. I mean, people die from these kind of bleeds because essentially this is a blood vessel that's ruptured and is bleeding into the esophagus. And so you need to fix that. So what we do, we come in and we actually do what's called banding. So we literally put little tiny rubber bands on these blood vessels. We literally put our scope and we suction it into our scope and into our channel and then put a little rubber band on it. We have a cool little machine but a little mechanism that does this. And so you put a little rubber band on them and you make them scar off and stop the bleed, hopefully. Sometimes it doesn't work. Sometimes patients have to go to other procedures to help stop the bleeding, but you hope that this works and you hope that you can fix the bleed and stop the bleed. So these obviously are real cases. This is one that I think, a patient that I recently saw, these two pictures, I think this picture is a patient that I recently saw that's a normal esophagus. So we do some pretty cool stuff, and it gets your adrenaline pumping for sure when you come in and you get called in the middle of the night for these kind of cases. So that's one thing about my job that's nice, and it's not every program is like this, but for me, I actually don't take night call. The GI fellows and the GI physicians do in our transplant center or in our GI department. So the nice thing is I actually don't typically have to go in the middle of the night. There may be a rare occasion where there's someone with acute liver failure that I might have to go in the middle of the night to see. But typically, and I do get calls in the middle of the night sometimes, but most of the time I don't need to come in the middle of the night, which is really nice. During GI fellowship, we absolutely do get called in the middle of the night. So when you're kind of deciding what fields to go into, that plays a role too, deciding, okay, do I want to be on call at night? Do I want to have to come in the middle of the night? The nice thing about this is usually, you can be in and out within an hour potentially. So you might go to the hospital and get called in for something. You might do the procedure and then be home and you're home within an hour. But other times it could take several hours. So it all depends. But it is a very satisfying thing to be able to treat these and to fix the bleeds and then save somebody's life, essentially. I mentioned foreign body removal. So this is an actual picture of a patient of mine from a couple years ago. So that is a key in somebody's stomach. That is what you're seeing. So this is an X-ray of somebody that swallowed a key. It is in their small intestine. Well, it's kind of in between their stomach and their small intestine in an area called the pylorus. And we removed it. So this happens not infrequently. You'd be surprised. Yeah, this happens. It's part of our job too. It's makes for a good story. But we do go in and people swallow all sorts of things, and so we do go in and retrieve them. people also get what's called a food impaction. So sometimes when people have diseases or disorders of their esophagus, food can get stuck in their esophagus. And so they might come in at all hours of the day saying that they can't swallow, and they can't swallow even their saliva, it's not going down. So we go in and have to remove the impaction, and we sometimes can push it into the stomach, sometimes we have to remove it. And so that's part of our job as well. I don't get to see this as much anymore, just because I'm more on the hepatology side of things, but as GI, you definitely encounter this not infrequently. So screening colonoscopy, just a few pictures for this. So that's a picture of a polyp that I recently saw in a patient's colon. So this turned out to be a precancerous polyp that I removed, and the way I removed it was doing what's called snaring. So you literally kind of lasso it. You have this little tool that sticks out of the scope, the end of the scope. You open up this little snare, you put it on top of the polyp, and then you cut the polyp off, and then you suction it into your channel. And that's how we remove polyps. So it's pretty satisfying. It can be pretty fun. It can be stressful because people can have really big polyps. They can have polyps that then bleed. So you have to deal with the bleeding afterwards. But overall, when you remove these polyps, it's again pretty satisfying, because you can say, okay, well, I'm preventing colon cancer here. So this is a great thing that we're helping patients with. Okay, so what do I do now? So I kind of mentioned that I do a lot of different things. So as a transplant hepatologist, I'm kind of a little bit of everything. I'm a clinician, I'm a researcher, I'm a teacher. So as a clinician, most of my job is clinical work. So I have outpatient clinic where I see both general hepatology patients, and then I see transplant patients. I do endoscopy outpatient as well. So I do these screening colonoscopies and endoscopies. And then I also do the inpatient hepatology service. So that means the year is split up between all of the hepatologists in our department. And we take turns being on the inpatient service. So we are on call essentially from 8 a.m. on Monday to the following Monday at 8 a.m. So we're usually in the hospital from about 8 a.m. to 5 or 6 p.m. But then people can call you kind of throughout the night. And it's just basically seeing all of the patients who have liver disease within the hospital that we get called about. So let's say there's a patient with cirrhosis in the hospital who's there for issues with their liver or potentially not issues with their liver, and they call us to manage their liver disease. Then I'm also a researcher. So I do research studies. I participate in kind of different things that I was doing starting in fellowship and then kind of finishing up now. I'm participating in some multi-center trials. So I participate in different societies, and through one society, there's a group of physicians that, we team up and we say, okay, we're going to do this research study. And there's a bunch of centers that do it all together so that we can get some really good data and understand different disease processes. I write review articles and manuscripts after we've conducted research projects. And then I'm also a teacher. So I do medical student lectures. I have residents rotating through our clinic. I teach residents rotating through the inpatient clinical service. And then of course I work with our fellows very closely on the inpatient side, and then on the clinic side. A lot of times they rotate with us through the clinics as well. So I really like my job this way because I get to do a lot, and I'm never bored, and I'm doing a lot of different things and wearing a lot of different hats, and it just keeps things really fun and fresh every day. So my day-to-day, I kind of mentioned this. So I, again, have this general hepatology clinic. Previously, obviously, it was all in person, but now we do a lot of telehealth. And actually, now we're about 50-50 back in person and still doing a lot of telehealth, video visits as well. And for hepatology, it actually works really well because a lot of it is really based on labs and looking at their blood work. A physical exam is absolutely essential for these patients as well, but we make do with what we can. So it's very helpful to be able to do the telehealth for patients because at our center, we actually treat patients who are coming from 4 or 5 hours away. And so this makes it much easier for them. Again, I have patients in the liver transplant clinic. I also see patients in the VA clinic. I do endoscopy. I have research time. I'm also have an administrative role. So I'm an assistant program director for the Transplant Hepatology Fellowship. So at our center, we have 9 total GI fellows, so 3 per year. And for the Transplant Hepatology Fellowship, so there's typically 1 or 2 transplant hepatology fellows at our center. So transplant hepatology is actually a pretty small field. I believe there are only 40 spots for a transplant hepatology fellowship around the country. So there's not that many people going into this field. And, you know, I absolutely love it. And there's typically places that have open spots. So if people are, you know, want to pursue it after GI fellowship, there's usually availability, but it's pretty small. And so it's kind of, you get to know a lot of the other hepatologists at different centers because there's not that many of us. And so it becomes this kind of really tight knit community. And I really enjoy that about this field. So, and then teaching. So I run the hepatology portion of the M1, M2 course and do lectures and do some coursework and record some lectures for them as well. And so I've kind of alluded to a lot of this already, but why did I go into GI hepatology? So the first thing is that you get to see a variety of diseases to treat. And so you're always seeing different things. I really liked I think I started liking GI hepatology even during my M1, M2 year when we were doing pathology and pathophysiology. And every time we would do GI hepatology, I was just like, enthralled. I just loved it. I was like, wow, this is so cool. Like their liver enzymes are elevated. We got to figure out why. It's kind of a mystery. We have to figure out where they're bleeding. So I really enjoyed that part of it. And then as I proceeded through medical school, I was like, okay, yeah, I actually do like GI and hepatology. I definitely never thought I would do transplant hepatology. It was not on my radar really even until I was in residency and did a clinic with one of the liver doctors there. That I had become my mentor, and I really enjoyed the clinic. I was like, wait a minute, this is great. I love this. Maybe I'm going to do GI. Maybe I'm going to do transplant hepatology. And so during fellowship, I kind of solidified that plan, and that's how I ended up getting to transplant hepatology. But that was never my initial intent. Actually, when I was finishing medical school, I wasn't even sure if I was going to go into internal medicine. I was actually between internal medicine and OB-GYN. I loved OB-GYN. I loved my rotation during my M3 and M4 year. And I really thought about doing that. And then I kind of looked internally and said, well, I don't know that I want to do surgery. So I was like, okay, well, if I don't want to do surgery, then I'm going to do internal medicine because obviously OB-GYN, a lot of it is surgical as well. And I didn't want to be on call all the time. I didn't want to have to, you know, come in the middle of the night all the time, even though I still ended up doing that during GI fellowship. But it's a little different. So that was kind of how I ended up choosing this field. You see a lot of interesting pathology. You get to do office care and procedures, which I really enjoy. And you get to make an immediate impact. So as I mentioned, you know, you go in, you stop the bleeding ulcer and you saved a life. So it is rewarding. You have opportunities for research and teaching and the people you meet. So it's interesting, you know, you end up kind of noticing different personalities in different fields. And I noticed that the people in the GI hepatology department were people I clicked with really easily and people that I was able to interact with really easily. And I was like, you know, I think these are my people. This is where I belong. This is where I feel really comfortable. We have a lot of similar personalities. And so that's kind of where I was like, okay, yeah, this is definitely where I am supposed to be. And you get to practice preventative medicine. So obviously we're intervening on things that have already happened and people developed cirrhosis, but if we can intervene earlier and prevent colon cancer, or prevent a bleed, or prevent cirrhosis, that's a really rewarding thing too. And so I do really love this field because of kind of all the things that we can do with it. So as I mentioned, it's okay to change your mind. I thought I was going to do OB-GYN. I wasn't really sure. I thought about emergency medicine, but then I did end up going into internal medicine. The other thing is you're not going to like everything in every single specialty. So even in, you know, if you choose internal medicine, you're not going to like everything about internal medicine. So pick the place that you feel like you like the most of the stuff, and then you can deal with whatever it is that you don't like. So let's say, you know, take GI hepatology. I don't love treating diarrhea. It's not my favorite thing to do. But I'm okay with it. And I love all the other stuff. So, I'll take the good with the bad. So you got to kind of feel it out and figure out what it is you like and what you don't like. And so take notes and kind of look internally and think, okay, what is it that I really like about this process or don't like about this field? And what it is that makes you happy. And mentors may lead you down a path you didn't expect first, just like the mentor I had during residency that was a hepatologist, and I rotated in his clinic and was like, wait a minute, I kind of love this. So it's okay to change your mind. It's okay to go a different path. Get involved early though, because the earlier you get involved, the earlier you realize what you like and what you don't like. So get involved in research, even if it's not in the field that you may end up in the future. If it's an opportunity that presents itself to you, take it, get involved, find mentors. So I always found this difficult. I was like, well, how do I find a mentor? How do they know they're my mentor? How do I know I'm their mentee? It doesn't have to be such a rigid process. It's somebody really that you just click with. And it doesn't have to be someone in your field. It doesn't have to be somebody that you can have multiple mentors. It can be, you can have a research mentor. You can have a life coach mentor. You can have a career path mentor. So you can find different people that help you along the way just to figure out where it is that you need to go next. So you can have more than one mentor. You can have mentors not in your division. You can have mentors not in your state. This really lends itself to that process with finding people and that you want to connect with or get more advice from. And if you get involved in like different societies, like medical student associations, things like that, that's another way to network and meet people. And that's kind of how, opportunities present itself to you. So a little bit about liver transplants. So I mentioned I don't actually do the actual surgeries, but I take care of patients with liver transplant. So liver transplant wait list as of May. So just last month when I looked, there was over 12,000 patients on the list. And in 2020, there was about 9,000 liver transplants that were performed. So obviously patients aren't always getting transplanted. So people are dying on the wait list because we don't have enough livers for everybody. The majority of transplants are done using deceased donors. So that means taking someone that has passed away and taking their liver and transplanting it to somebody else. But you can also do living donors. So as you can see the numbers, living donation is not as common. So deceased donor liver. So I mentioned I don't do surgery, but this is actually me with one of the transplant surgery faculty. So during my Transplant Hepatology Fellowship, I actually needed to observe several transplants. So obviously I knew what was happening. And it was really fun. I'm not gonna lie. I was like, oh, maybe I should have done surgery. But I can't stand on my feet for 12 hours. I couldn't do it. So this is us doing a liver transplant. I did get to help a little bit here, and it was really fascinating and amazing what they do, and I commend them for it. So a deceased donor, as I mentioned, this is the most common type of liver transplant. The waitlist is based on something called a MELD score. It's a score that takes into account 4 different blood test values for the patient, and it estimates their risk of death within 90 days. So the higher the score, the higher risk of death, the higher you are on the transplant list. And then living donor donation is pretty fascinating. So the body has the ability to regrow your liver, which is amazing. So in a living donor transplant, you remove typically the right lobe of the liver, which is over here. So you take about 65% of the liver from the donor and give it to the recipient. And in about 6 to 8 weeks, both the donor and the recipient sections actually grow to the size of normal livers. So it's pretty incredible. But only about 5% of total liver transplants are from living donors. And that's because, you're still putting the donor at risk. You're taking somebody that's very healthy and putting them through a big operation to remove part of the liver. So people have to be very, very healthy to be able to donate part of their liver. And so it's not a big chunk of the number of transplants people do, but it is definitely something that's available for patients and an incredible way to give people a second chance at life. So I've kind of tried to give a little bit of advice throughout this presentation, but again, use all the resources available to you. Don't forget to do things for yourself. It's a long and arduous process, and you guys deserve to have some fun too. So make sure that you're carving out some time for yourselves. seek out mentors, as I mentioned, get experience early on, mostly so that you know this is something that you definitely want to do, and figure out what you want to do. And it's definitely okay to change your mind. You know, you can always say, well, I thought I was going to do this, but I'm going to do this. And that's okay. That's absolutely okay. You have to love what you do. And, you know, I'm lucky to say that I do love what I do. I didn't know exactly what path I was going to take. And kind of along the way, just figured it out slowly but surely. And I'm really happy with where I am today. And that's all I've got for everybody.
Thank you so much, Dr. German. So I believe we can move on to the, oh, sorry, there we go, to the Q&A session over here. So I'm gonna start asking you questions that are a bit more case directed, and then we can move on to the general topic questions.
Sure.
Okay, so the first question that I have over here is from Angela. So Angela asks, is banding a permanent solution? I believe that is regarding the second case that you presented.
So those little rubber bands actually fall off after about a week. So we put these little rubber bands on and it makes the varices scar off. And so that band actually just gets, you know, pooped out. Patients don't even notice it, but it actually falls off after about a week. And then we actually have to go back in a few weeks to do it again. Because when you do it the first time, it doesn't mean that they're completely gone. We typically bring them back in about 3 to 4 weeks and do it again. So if they've got big varices again, we'll go ahead and put little rubber bands on them again, and then they'll scar off, and then we'll do it again and again and again until they're gone.
Okay, thank you. So another question regarding that same topic, Daphne asks, are the bands put at the bottom of the varies, and do you only put the bands on the varies that is bleeding or on all of them?
Great question. So yes, so it's essentially, we kind of create a little polyp. So we suction up the little, the varix into our scope, and then we put the rubber band right at the base of the polyp. So the varix is kind of sitting up here and we're like choking it off at the bottom. And we put it on the one that's bleeding, but also all the other ones, because you're kind of trying to decompress the system. And so if you just put it on the one that's bleeding, you know, you try to put on, sometimes you can't put it on all of them that are there because, you know, patients are unstable or something else, but the goal is to stop the bleed, but then to try to band all the ones that you see. Yeah.
Okay, wonderful. So Janelle asks, what exactly are you placing the bands on? I believe you would just answer the question with, you make like little polyps you mentioned?
Yeah, it's literally a blood vessel. So we are putting a band on a physical blood vessel. So think about varicose veins in legs, you know, it's essentially that, but bigger. And so those pictures that I showed, that's literally a blood vessel. It's a vein that we are suctioning into our scope. So it's scary because you're literally, I mean, you can suction it and it can burst open and bleed on you. So we're suctioning it into our, kind of putting a little rubber band to make that vein scar off. So it's literally a vein, just like, you know, you look at a vein in your arm, that's the same thing, just a lot fatter, a lot bigger.
Okay, great. So Cassidy asks, okay, this word is kind of hard for me. Do esophageal varices interfere with swallowing, and do patients need to avoid certain foods?
Oh, good question. So the esophageal varices, they cannot feel them at all. So you'd have absolutely no idea that you have them unless we do an endoscopy. So it doesn't interfere with swallowing. It doesn't interfere with anything. They don't need to avoid any foods. Once we put little rubber bands on them, they can be a little bit painful for them at first, especially if it's higher up, because further below, they don't really have pain receptors there, so they wouldn't feel them. But for the first couple of days, we tell them to have some clear liquids so they don't knock off the rubber bands, you know, if they eat a huge chunk of steak. But then after a few days, it just scars off. But no, you can't feel the varices at all.
That is very interesting. Thank you. So Nikki over here asks, how do you make sure you retrieve all of the polyp?
Oh, so that's actually a great question. And that's something that we learned during our training, that a lot of times you can kind of, if they're really small polyps, you can kind of bite it off. We have these little not clips. We have these little, kind of like tweezers, but little like claws, and you literally like just bite a chunk of it off and pull it off. And that way you can get one of the polyps, and then you can, with the snare, you have to put the snare all the way around the whole polyp and make sure that you do get the whole thing, because if you're leaving parts of it, that still leaves the potential for that to turn into cancer. But we're also bringing people back sooner. So if you have polyps, you're more prone to making more. So we're, instead of saying, oh, come back in 10 years, we're telling you to come back in 3, 5, 7 years, depending on the number and type of polyps you have. So there, as long as you remove most of the polyp, you have the capability to come back and then make sure that it's all gone. But typically, I mean, that's a great question. That is the whole point, is you have to be a good endoscopist and take the whole polyp off so that they don't have the potential to leave a little bit, and then that can turn into cancer.
Okay, wonderful. Thank you. Okay, so this one was regarding the liver transplant. So Daphne asks, why do you take out the right side of the liver and not the left one?
Good question. So for an adult, if you were to only take the left side of the liver this is specifically for a living donor donation. If you have a deceased donor, so if somebody's passed away and you're using their liver, you take the whole thing. So you're taking the whole liver and giving it to the person and removing their old liver and putting it in. But if you have a living donor, you have to, if you just take the left lobe of the liver, it's not enough. So it's not enough liver to give to an adult person for it to regrow and let them live. So you have to take the right lobe, or sometimes you take the left lobe plus a bit of the right, but typically you're taking 65% of the living donor. So the person that's giving part of their liver, you're taking 65% of that liver and giving it to the person whose liver you have to remove. And so taking the left side, it's just not enough tissue. It's not enough liver for them to live on. Does that make sense?
Yeah, it definitely does. Thank you so much. So Rohan asks, how are patients who have cirrhosis due to alcohol abuse handled in terms of receiving a liver?
You hit on a big topic there. So it's a very interesting topic, and very, I wouldn't say it's controversial. So we transplant, alcohol is actually the #1 reason for patients receiving liver transplants. Number 2 is this entity called NAFLD, non-alcoholic fatty liver disease, the fatty liver that I mentioned, related to people with obesity, diabetes, things like that. So we transplant a lot of patients with alcohol use disorder. Previously, you may have heard, let's say people can't get transplanted. Sorry, I just got to plug my computer in before it dies. People can't get transplanted if they've been drinking within the last 6 months. Well, that's not a rule we use. That's not a rule that predicts who's going to survive. It's not a rule that predicts who's going to go back to drinking after transplant. It's not a rule that predicts who's going to do well after transplant. So we do not use that rule at our transplant center. There are certain transplant centers throughout the country that still use that still use a 6-month sobriety rule, but our guidelines have caught up with it and say now that you shouldn't use that cutoff because it's not predictive of who's going to do well. So we actually transplant patients who, there's an entity called alcoholic hepatitis. It's an acute inflammation of the liver when people have underlying cirrhosis. And people can die, actually 75% of those people will die within 6 months without a liver transplant. So how can you tell all of those people they have to wait at least 6 months to not drink if they're going to die within those 6 months? So that's where my job gets really difficult, is trying to figure out which person can we say, yes, you can get a liver transplant to based on, your alcohol use and other things, versus who you can't. And that's why we have a huge team of people. We have a psychologist, we have an addiction medicine specialist, we have a social worker, we have a transplant hepatologist, we have a surgeon, we have mental health providers. We have all these people working together to try to figure out who is going to be the best steward of these organs, who's going to take the best care of these organs if they get a liver, if they get a donation, if they get a transplant. So it's a really, really tough decision, and it's a really hard decision because a lot of patients will die if they don't get a liver transplant. And so trying to tease out those, and we know, there's certain things that predict who will do better and who will do worse. So people who have known about their liver disease for years and years and kept drinking, those people aren't going to do very well because they didn't change when they already knew about their liver disease. They're unlikely to change later on, but not always. So it's not a, it's a very case by case individualized decision, and very difficult. But we have patients who come in the door, they were drinking on Friday and they may get transplanted in 2 weeks. And so, because those patients are going to die if they don't get a liver transplant. And so that's why we do this huge assessment with addiction medicine and social workers, helping us try to come up with a decision of saying, well, these patients, do we think they're going to drink after transplant or not? And if they do drink, how can we help them? So it's a very, very tough decision.
Thank you so much. Yeah, for sure. I like how you mentioned that it's really a team effort, as many things in the healthcare field.
Absolutely.
So Riley asks, what are the symptoms of cirrhosis and what is the difference between fibrosis and cirrhosis?
Good question. So first I'll touch on the difference between fibrosis and cirrhosis. So fibrosis is essentially a term to just say there's scar tissue in the liver. Cirrhosis is a term to say that there's significant scar tissue in the liver. So there's stages of fibrosis. It goes from F0, stage 0 to stage 4. Stage 0 means no scar tissue. And then it goes 1, 2, 3, 4. And stage 4 is cirrhosis, so significant scar tissue. So they're kind of one and the same, but it just means cirrhosis is just a lot of fibrosis. And then symptoms, most patients are asymptomatic. For the majority of the time they have, for a long time. It's not until they really have advanced disease, advanced cirrhosis, that they develop things like, their skin turning yellow or their eyes turning yellow, jaundice, or they get swelling in their belly because they develop what's called ascites or fluid in their belly. Sometimes they get confusion, which means encephalopathy. So those are kind of late signs of cirrhosis. Really, a lot of times the way we know people have cirrhosis in the beginning is when we check their liver enzymes and they're elevated. So we check their blood work, or we do, a scan. We look at their liver for something else, or we look at they get a CT scan for something else. And then you notice, oh, wait a minute, the liver looks a little bit scarred there. And a lot of times you see fatty liver before you see scar tissue. And so we can kind of predict and follow people. If they have fatty liver, then we try to prevent them from progressing to cirrhosis, but sometimes they still do. And sometimes they come to us only when they already have cirrhosis. So a lot of times it's really an asymptomatic disease, which is why people a lot of times don't know until it's too late, until they're really, really sick.
Okay, thank you again. So one question that we have from a lot of our audience members, here we begin with the more general questions. So with so many responsibilities and tasks, especially as a mom in a male-dominated field, how do you maintain your work-life balance?
That's a great question. So I will say that working in an academic center has given me more flexibility for work-life balance because I have a lot of other partners in the field. So let's say the inpatient service. So now, when I came to UW as a fellow, there was only 4 or 5 hepatologists, and now there's 8 of us, even 9. And so it makes the work spread out between different people. So you don't have to do the inpatient side that often. The times where I'm on call from 8 a.m. to 8 a.m. So those are weeks, I maybe do 8 to 9 of those a year. So that gets spread out pretty well. So I don't work that many weekends, but the weekends I'm working, they're pretty busy. So that makes it easier for me. Again, with a transplant hepatologist, I don't have to come in the middle of the night, which is really nice. If I were doing just GI and working in a private practice, I'd probably be coming in, sometimes depending on the number of people, you might be coming in every 4th or 5th night, depending on what's happening. So I feel like academic medicine actually gives me a little bit more flexibility in that sense. So, and because I'm doing research time, actually, I have a day and a half of what's called administrative time. So it's my own time. I'm not in clinic, I'm not doing endoscopy, I'm doing what I need to do. So that might be catching up on patient care, that might be finishing a research project, that might be doing something like this, that might be giving a presentation. So it really gives me a lot more flexibility. Whereas sometimes in private practice, you end up having, you know, every single day is filled with clinic or endoscopy or procedures. So that gives me flexibility. My department is really family friendly, honestly. You know, I would say that 95% of the people in my department have kids and have had kids during fellowship. I think out of the 9 fellows we have right now, I want to say 5 of them are either pregnant or their wives are pregnant and expecting. So it's also a very family friendly fellowship, which, you know, it just breeds kind of the right kind of people. So it definitely is department, definitely is practice oriented, I would say. But I'm lucky to have found the place that is really conducive to what I want to do. So it's true that I'm doing all these things kind of all at once, but they kind of ebb and flow. So clinic, I'm always doing endoscopy, but maybe one week will be, I'll have to do, you know, a research project and write a paper, but the next week I don't. So the next week I focus on something else. So it kind of ebbs and flows. So you're not doing everything all at once. You're kind of spreading it out as you go. So I always wonder the same thing, but typically I will say that I usually work from about 8 a.m. till about 5:30 p.m. That's my typical day. And then I'm not going to lie, usually I'm working, you know, once I take a break at 5:30, I spend time with my family, I put the kids to bed. And then a lot of times I am, you know, maybe chart reviewing or prepping for the next day, you know, at nighttime for an hour or two. So it's busy. It's definitely busy, but I still enjoy it and I enjoy what I'm doing. And that's kind of how I get to, you know, stay sane.
Okay, I love that. That sounds absolutely wonderful. So, one question we have over here is from Victoria. And the question she has is, when should you start having regular scopes, male versus female type of situation?
Yeah, so in general, we used to say 50, age 50 for men and women was the age you start doing screening colonoscopies. But now they just lowered the age to 45. So we're kind of slowly starting to adapt that into our practice, where we start screening patients at age 45, men and women. It does change depending on if you have a family history, if you have inflammatory bowel disease, then you start screening earlier. So it just all depends on when you're, you know, if you got a family member that had colon cancer, a first degree family member, let's say at age 40, well, actually, you would start actually screening 10 years younger than that, so 30. But if you don't have a family history, if you're relatively healthy, you don't have any inflammatory bowel disease, then 45 is for men and women.
Okay, that is wonderful. So, unfortunately, we have run out of time, but I want to thank you so much for joining us today, Dr. German. I'm gonna share my screen real quick so we can begin with the wrap up for this session and get everyone ready for their shattering assessment. So once again, I want to thank you so much, Dr. German. I believe this was a very informative presentation, and I do think we all learned a lot from it. So considering this, we would like to encourage everyone in this session to reflect on this session today. And you can reflect on these 3 questions that we have over here. So what brought you to the session today? What are 3 major takeaways that you got from it? I know that there's a lot from it, at least in my opinion. And what do you want to learn more about? You can definitely write some answers to these questions. You can just think about them, answer them in your head, however you want. But if you do write answers to these questions, even though it is not required, we encourage you to submit it to our website for publication, for recognition of your hard work, and to enhance your future applications. I would also like to mention once again that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research in a variety of topics, fields, and locations. And I want to highlight once again that it is 100% remote, which means you have the power to connect with anyone in any field that you may like. It is an 8-week program that will begin on June 21st. And for more information, you can fill out the interest form that was sent in the chat, and we will get back to you as soon as possible regarding more information about it. If you want to learn more about pre-health shadowing and how to get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and also social media promotion and much more. We are also accepting team member applications if you want to take on a more active role in PHS to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able, that you please consider doing so. It does cost a lot to keep our program up and running and free to all of you. So if you're someone who can afford to, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you spread the word about pre-health shadowing to reach as many students as possible. Now for the part we have all been waiting for, that is earning a digital certificate for the virtual shadowing hours from this session today. So the first step is you're going to go onto our website and find our professionals course pages. In this case, Dr. German's page. There you can take our quick 10-question multiple choice quiz based on the content from this session today. You will have 30 minutes per attempt to earn a 70% or higher to get your certificate. We do know, of course, that sometimes technology can be difficult, and for this reason, we allow up to 2 attempts to take the assessment. But if you do run into any difficulties, please do not hesitate to contact us. To ensure that our website does not crash from a high influx of students, we do recommend waiting about 30 minutes to an hour after the session to take the quiz, which will be open indefinitely. And finally, once you have passed, you can click the Finish Course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. If unfortunately you missed a part of the session or you want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for these as well. Be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming events and sessions. We are currently booked every weekday through June for virtual shadowing sessions, so we definitely hope to see you guys over there. Once again, thank you all for joining us today, and please stick around if you have any questions, and myself and other team members will definitely be happy to answer them. This shadowing session is officially over, and I invite you all to log off. Have a wonderful day, evening, or night, depending on where you are.